Sama login karo. Close करছি। এডি পাসওয়ার্ড দিই না।
Insight. Insightful.
Morning. Should I just start the PowerPoint slides or are you going to introduce Laurent?
So I have to introduce the conference, I think.
Okay.
Okay, so I have to read something before. So
So you're going to do that. Okay, and then I'm on. Okay, I was just confused.
okay. Sorry, I think it's to me to choose that. So good morning, distinguished guests, esteemed colleagues, speakers, and delegates and participants. It gives me the immense pleasure to welcome you all the 5th World Science, Neurology, and Brain Disorders Summit and the 5th International Neurosurgery Neurological Surgeon Conference taking place from January 14 to 15th, 2026 at Novotel Al Barsha, Dubai, United Emirates, and online. About UCJ conferences, Italian Conferences Gathering, UCJ, for the leads in organizing professional meetings, conferences, workshops, and symposiums across the medical, clinical, healthcare, life science, and pharmaceutical sectors. UCJ bridges academia and industry, driving excellence and innovation in every event it organizes. With global reach every day and a dedicated organizing team, UCJ ensures that each conference is impactful, memorable, and tailored to the needs of its participants. On behalf of UCJ, I extend heartfelt gratitude to the organizing committee, our esteemed speakers, and all participants whose contributions have made this event possible. Together, we are advancing the future of the neuroscience and neurosurgery worldwide. So I'm Dr. Laurent Vinikoff from Andorra, the very small country between France and Spain. And it's an honor to me to serve as the chairperson to this prestigious event. This conference brings together leading experts, innovators, and practitioners from around the globe to share the latest advances in neuroscience, neurology, neurosurgery, and brain research. Over the next 3 days, we will explore groundbreaking research, emerging technologies, and innovating clinical practice that they are shaping the future of brain health and neurological care. On behalf of the organizing committee, I extend my heartfelt gratitude to all the speakers, delegates, sponsors, and participants who have made this event possible. Your presence reflects your commitment to advancing neuroscience and neurological care, and I'm confident that the discussions we have here will lead to mindful insights and collaboration. With that, it gives me great honor to officially open the day 2 of the 5th World Science, Neurology and Brain Disorders Summit and the 5th International Neurosurgery Neurological Surgeon Conference. Let us make this day 2 productive, inspiring, and memorable. So it's my pleasure to introduce your first speaker, Ms. Farah Qureshi, neuroscientist and neuromarketing specialist. She will be delivering her speech on rewiring the mind, interactive approaches to brain health using QEEG, neurofeedback, hypnosis, and coaching. Please join me in welcoming Ms. Farah Qureshi. It's your turn now.
Yes,
Welcome.
thank you so much, Laura. Appreciate it. Thank you so much. Okay, I will try and share my screen. Okay, there we go. Share. Okay, and then I can present, I think, yes. Everybody can see my screen now?
Yes, that's okay.
Amazing. Okay, so rewiring the mind from brain data to lasting change, as Laura just beautifully introduced me. My name is Farah Qureshi. I'm based in Denmark, in Copenhagen, and my company is called Neuroconsulting. So today is much more about only the brain. It's about the brain, but we're going to try some fun exercises so we can actually understand what I'm trying to do with this PowerPoint. We have to wake up, right? Why I'm doing it a bit differently because the brain, and many people say it's a complex organ. For me, it's about understanding it. Then we have to experience it. So I want to do an exercise with all of you. It's our first brain challenge of this morning. I hope you're able to. I know we are virtually together today, but everybody can do this. If we have 2 hands, then it's easy. I'll show you. So the first brain exercise we are going to do is that I want you to take your right hand and draw a line, a circle in the air. Yes, but then you have to take your left hand and draw a square at the same time. Well done, Laura. Now switch circle and then the square. It's quite hard, right? It's not that easy.
Harder. But it's possible.
It's harder with the left. I felt the same thing. It's easier with the right. That's because I'm right-handed, and you're probably right-handed as well. So what did we just experience right now? A neuroconflict. Our brain juggling 2 competing networks, okay? Several brain areas being activated, the PFS, the ACC, because focus and regulation, they're not just willpower. It's about brain communication. It's kind of hard to do those 2 things at the same time. So that's why I wanted to demonstrate it. Why did we even do that exercise? Because I wanted to demonstrate that in today's society, many tabs are open. We often have 12 tabs on our laptop. That's just one example, but many tabs mentally are always open. Our brains are overloaded. And I work with clients from all over the world, especially London and Copenhagen. I also had clients in Dubai, actually, but they were all coming with the same problem, which was I'm not able to focus. I'm feeling overwhelmed. I think I have dementia. I have brain fog. It's like, no, you're just stressed. Okay. So let's talk about the tabs that are open. The thing is, people have high leading jobs in companies. They're doctors, they're surgeons, they're neuroscientists, but they're not really taking care of themselves. So this is a picture of anxiety, how it can look in the same brain. Is different brains, but how it can manifest in your brain from a QEEG scan. I will elaborate further on this. I just wanted to show you this. So in mental health, we treat symptoms, not the source. So a QEEG scan, I will go in details with it very soon, is that we do it on a nervous system level. So a person can have anxiety that manifests in the terms of, I can't focus, I have brain fog. The other one has anxiety and stops doing everything. So it can manifest very differently. And sometimes people need more activation, whereas some people need to do less. So without data, we're always guessing, and guessing is very expensive. As many people come to me before having a scan and they're panicking because they have diagnosed themselves with ChatGPT and and they think they have all kinds of symptoms and it's worsening their anxiety basically. So right before we dive deep into more in depth about QEEG scans, I want to have a look back about the brief history of brain scanning. It's always been existing, okay? It's always been there. And before, it was more about observing the brain, where EEG showed activity, what was happening. But now with the QEEG brain mapping, we can measure and map it. So we go from observation to measurement, and that kind of is a game changer for neuroscience today, I would say. In the old times, I was reading a book yesterday about the gender brain. And in the old time, they used to even measure the skull. And it was only the men that was measuring. The women were supposed to just stay at home, not educate. This is back in the 1800s. They were measuring the skull and they thought that intelligence was linked to the skull size. That was back then. So we have come really far ahead that we can really like measure data on such a detailed level, you know.
Mm.
So what is a QEEG for those who is not familiar with it? You wear this cap. As you can see, it's actually one of my clients. I did this in London. You wear this QEEG cap. It's an EEG cap. It's non-invasive. You use gel. You inject it. And you just need to have connection with the software. It's very easy. And depending on the hair, it takes longer with some clients than others. You will be easy to scan, Laurent, because I just need scalp connection. It's very easy. We need the scalp connection so through the hair. So sometimes when people come with really thick Indian hair, it takes longer for me. But what it does is that we can actually measure on, as I said, on a nervous system level. We can see sleep, we can see memory, we can see cognitive functions. We can see trauma, we can see if they're neurodivergent, but it's not a diagnostic tool, but we can see if they are, if they have epilepsy, high, low blood pressure. So it's very much detailed. But don't forget that, like I just said, it's not a diagnostic tool, it's a map, okay? So it shows whether the brain is overworking, underworking, or stuck in survival mode. The most clients that I've scanned, their nervous system has been overdrive, meaning anxiety levels has been high, cortisol levels been really, really high. They've been very much stressed out. So our brains has rhythm for every state, from deep rest to focus. So I'm just going to put this up. So these are all the brain waves that we're supposed to have: delta, theta, alpha, beta, and gamma. Sometimes people don't have that. That's already an imbalanced brain. Oh, yes, you shouldn't be surprised, Laura. Now you're the only one I can see, so I just saw your expression. Oh, yes, you will be surprised. Some people don't have alpha. They're so stressed out. They're lacking alpha. So imagine a person who doesn't have alpha, meaning they don't know how to be calm. They don't sleep properly. They sleep, they wake up, they sleep, they wake up. Because we do need all these brain waves in order to function properly. And the good thing is we live in an era of technology. So today, if you don't have it, we can insert it through neurofeedback. I will get into that as well. So I've had clients, many of them with a nervous system that is overdrive, has a lot of beta, like too much beta. So the goal would be to reduce some of that beta and balance it out. Some people have too much alpha frontally. That's a typical, and theta and delta. So that's more like an ADD profile. But then they have a hard time focusing. They procrastinate. This is one of few examples, right? So we are supposed to have all these brain waves. Just wanted to highlight that in order to function properly, have a nice sleep, being able to switch off the taps. Otherwise, we will be kind of a prisoner of our own mind. So this is a little map showing you guys how from data you can take action. First, you do the scan. Then we measure the results to see if there are any imbalances in the client's brains. I don't call them patients as I'm not a doctor. I'm an applied neuroscientist, and this is not a diagnostic tool. So that's why I say clients. And then we map, visualize the neural pathways, and with that information, we turn it into how we can help them optimize or train their brain. So there's a lot of work to do from the scan to having the data, then to analyzing the data into brain maps, then writing it out as a report where they can actually take it and implement it. And we come with recommendations. So data alone doesn't create change. That's just information. But it's about taking that information and turning it into action that actually matters. So a scan without integrating it, so what do you need that scan for if you're not going to take some action and change it, right? Then it's just information. Mm-hmm. So we're going to do another small exercise, very quick one, just to test our alpha, okay? So let's close our eyes. And we're going to take a deep breath in like this, hold it for 4 seconds, and then slowly exhale for 4. Slowing your breath and just pausing for a minute in the presentation. Already in there is a soft clarity. Our brain is a little bit reset now. You can open your eyes, Laurent. That's alpha. I think it's fun to include these small. I could also have done a hypnosis. I do hypnosis as well, but we don't have time for it. But then our theta and delta would very much be in the forefront. But it's funny how we can go from high alert focus to just calmly close our eyes and take a deep breath. That does make all the difference for our brains, okay? So now that we have the brain map from the scans, it's about how do we train the terrain, right? Because you cannot, it's kind of like having a car, having awareness, but we're never moving it. So now we are going to talk a little bit about neurofeedback, the brain training. How do we use these QEEG scans to implement them for our clients? So neurofeedback teaches the brain to self-correct through feedback. So it's not about forcing change, but from the QEEG scan, we have their data and the protocols and how to work with the clients. So sometimes people do have often too much beta, they're very stressed, or they're lacking alpha, and it's our job to kind of balance their brain. So it's about inserting or reducing these specific brain waves into their brain. And with the equipment, we help them supervise sessions, but they can also train their brains themselves, because the more the brain repeats something, it rewires it, right? And it becomes that reality. So once the brain starts to learn new pathways in the brain, so I always say the brain is like kind of like my logo up there. It's like a tree. So we have to figure out the root of the problem first, and then we can go deeper, right? When we don't know what the root of the problem of the tree is in the brain, then how can we help them consciously make a change? Often people don't know after the scan, even like, I don't know why I'm stressed. No, I have a wonderful life. They live in denial or they don't know. So that's why hypnosis is another tool that I use with clients to kind of understand subconsciously what's going on, what is blocking them. Because often when people say, sometimes clients come to me and say, I don't remember half of my childhood. Okay. Trauma response, you block something. Then it's about figuring out what works with each client, as everyone is different. You can have the scan, you have the evidence in front of them, and their brain is still blocking it and not believing what you're telling them. That if we don't do something now, it might be too late later. As I've scanned burned out brains as well. No fun. So, okay. So alpha and theta is the gateway to change. That is what we use for hypnosis, especially. So the hypnosis that I do, they're all in controlled environments. And it's not like in the movies we see where we're like, you're a chicken now, and you're like, quack, quack, quack. It's not like that, okay? You are consciously there, but you're kind of like in a relaxed, sleep, calm environment. And my voice changes as well when I do hypnosis. I'm very calm, everything shifts. We are going in a slow pace, okay? But because I'm delivering a speech, I'm going in a higher pace because I don't have much time. But hypnosis is all about being relaxed, calm, trusting the person who's doing the hypnosis, who's giving the hypnosis to you. It's deep focus. You do enter the alpha, theta brain waves, delta as well. And you give, so the subconscious mind is always running, right? But then you're kind of letting it go. You're the wall that you had up front, the blockages or whatever, is kind of open now. There's a doorway you can enter. So hypnosis is a very strong tool to get some answers if you don't know what's blocking you, if you don't know why you can't remember half of your childhood. It's just an example. But even the powerful brain change won't last until we kind of bring it into daily life. It's all about habits, you guys. So that's where I coach as well. I coach businesses, I coach private people. I have groups where we do use neuroscience based strategies, because it's about understanding what your brain is trying to communicate, but implementing it in your daily life. So a habit can take a long time. On average, 66 days to become automatic. When I say automatic, it's like we brush our teeth every day. It's an automatic response. We drive the car. I don't have to think about it. That's an automatic response. So neuroplasticity, I always say to my clients, your brain is malleable. Your brain is always changing and evolving. It's not static, because they think, oh, I'm 50. This is too late for me. It's like, no, it's never too late to do any change in your life. So neuroplasticity is all about rewiring your brain, but it's about repeating and implementing and taking action every single day. So the process goes from brain mapping to the brain, to training it, rewiring it, and finally to living it. So we're going to do another one. So inhale with me for 4 seconds. And then exhale for 6 seconds. This is a longer one. So just like we did before as well, we took a deep breath. This is your brain saying to you, I'm safe. That's regulation, not relaxation. And we can all take those free deep breaths anytime, anywhere. I actually do it in between meetings. Sometimes my schedule is a bit hectic. I can feel overwhelmed. So I do take these deep breaths. I do live whatever I preach. So I could do better, of course. So we're going to wrap this up as we're running out of time, and our prefrontal cortex is totally locking off before the next one comes on. So QEEG gives the map, neurofeedback trains the brain, and hypnosis accelerates change. You get some answers from your subconscious mind you were not aware of, and coaching make it less. So this is how we go from symptom management to self-mastery. So just to sum it up very quickly, we started with confused hands, right? The left thing was difficult to do with our mischievous neurons. And we learned that the brain is never broken, even when it feels like it. We can do something to accelerate that change. the magic happens when we start guessing and talking to AIs to self-diagnose and actually go to a professional to get the measurement. Because when you train the game, oh, sorry, train the brain, you change the game. It's very easy. It sounded better when I practiced it. So that was it, you guys. I have nothing else. Please do connect with me. I would love to connect with you guys on LinkedIn or Instagram. I know the slides will probably be shared afterwards, and we're running out of time. So thank you for this opportunity. It's been a pleasure. I was the first one, so I hope every brain is alerted now.
So very nice, interesting presentation, Ms. Farah.
Thank you,
I
Laura.
think
I appreciate it.
I will contact you soon, I think. So
Okay, that's nice.
it's
That's
amazing
nice. I'm happy to
presentation.
hear it. Thank you.
As a
Thank you very
neurosurgeon,
much.
I was very interested in your work, and yes, it's very amazing work. So congratulations, Miss
Thank you very
Farah.
much. I'm very interested
So
in hearing about you as well and every other participant. And I know you have a schedule ahead. This is early morning, and I have 3 kids that I need to get to school now. So I will log off.
okay, yeah,
Thank you.
don't worry. So
Have a
thank
yes.
you so much.
Thank
Have a
you. Have
nice
an
day.
amazing day. You too. Bye.
Thank you.
Bye.
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 So now it's my honor to introduce our next or first poster presenter, Dr. Hatem Daoud from the Neurosurgery Department, Habib Bourguiba Hospital, Sfax, Tunisia. So Dr. Hatem Daoud will presenting his fascinating case report titled Giant Dilatation of V-shaped Robin Space, presenting with obstructive hydrocephalus, a case report. Please join me in welcoming Dr. Hatem Daoud, if he's ready. Are you here, Dr. Daoud? No. Monsieur Daoud. Ah, d'accord, okay. It's my turn. Okay. Then, sorry. Let me turn. Zoom. Comment on fait? Zoom, zoom, zoom. Okay. I would like to share my presentation, but no, it's not here. Okay. Yes, I would like to present my slides, but yes, partager l'écran, partager. Ah, yes, okay. I think you can see my presentation. Yes. Okay. Did you see my presentation or not? C'est pas ça. Does someone see my slides or not? Okay, thank you. So, good morning, ladies and gentlemen. Thank you for the organizing committee for the opportunity to present this work. Sorry? Okay. So today I will share my experience with minimally invasive surgical management of lumbar spine stenosis, MIS, and I will try to show you that this is an accessible and effective option. Next slide, please.
हेलो
Yes.
अगर वैसे चलाओ चल जाएगा अपने आप कुछ करने की जरूरत नहीं पड़ेगी अगर ना चले तब एक बार ऑफ करके ऑन कर देना सेटअप होगा
Okay. But can you? Yeah. Thank you. This is a slide 2. Yes. So lumbar spinal stenosis is one of the most common indications for spine surgery, particularly in the elderly population. And can you give me the second slide, please? Because this is the third one. Hello, hello. No, before, at the beginning, this is the next slide. Once more. Okay, thank you. Can it start? Okay, thank you. So, good morning, ladies and gentlemen, again. Sorry for the distraction. So, thank you for the organizing committee for the opportunity to present this work. I will try to share my experience with minimally invasive surgical management of lumbar spinal stenosis and show you that this is an accessible and effective option. Slide 2, please. Next slide. Thank you. So lumbar spinal stenosis is, I think, the most common indication in spine surgery. You can see the annual incidence, 5 to 11 cases per 100,000 per year, and it, of course, increases with age. Open decompression is effective is often associated with significant muscle injury, postoperative pain, and delayed functional recovery. So, next slide. Thank you. Next, yeah, so okay, thank you. So we have to recognize these patterns. Lumbar spine stenosis can present in various anatomic forms, as you can see, included degenerative. This is the most common with hypertrophy of the ligament and flavian facet joints, but it can be associated with degenerative spondylolisthesis and with synovitis. That means a high probability of instability, or a junctional stenosis above an arthrodesis. Recognizing these patterns is essential for appropriate surgical planning. Next slide. So, open decompression is effective, but with significant muscle injury. So, what do we mean in MIS? Minimally invasive spine surgery is defined. We can define it by muscle sparing approaches and limited soft tissue disruption. And the goal is not minimal exposure, but effective decompression with reduced mobility without increasing the risks compared with the referent technique. Next slide. Now, this is the gold standard. It was my life before. So you need to cut the muscle on the both sides to expose the posterior arch and to achieve the neural decompression. You know that. Next slide. So my evolution of my surgery approach initially started during posterior lumbar fusion procedures. I became aware that extensive paraspinal muscle damage could negatively affect postoperative recovery and long-term outcomes. This led me to focus on paraspinal muscle anatomy in order to preserve muscular structures whenever possible. These muscle sparing principles were then naturally applied to lumbar spine stenosis surgery, as the posterior surgical approach is essentially the same. Next slide. Now it was my life before. On the left side, you can see a pleth technique with a description of the posterior muscle chain. And on the right side, you can see interbody somatic fusion, but by extraforaminal approach with the good respect of the muscle and the good recovery of the patient. And thanks to the knowledge of the anatomy of the muscles. Next slide. That's why I've imagined a first technique that is derived from a lumbar disconnection approach. And this technique allows a direct visualization of the stenotic segment while minimizing muscle injury. So you can see here the approach between the muscle, the multifidus, and along the lateral face of the spinous process. Next slide. This is the surgical technique. So you perform the classical approach as for disconnection, but the difference is to cut the base of the spinous process with the curved sizer and to push it on the other side. So imagine here under the self-retractor, the line of the spinous process with the posterior ligament, interspinous process ligament that moved on the other side to expose the posterior arch. And after that, you have to achieve the neural decompression as usual. This is the first technique. And the second one, next slide. The second one is derived from a mini-invasive surgical for the lumbar disconnection, and that uses a tubular system. So you have to go now, not here, but through the muscle, through the multifidus muscle, and to apply this tube here. This is a tube. on the lamina, the interlaminar ligaments, and you have to remove all these parts, anatomical parts, to open the canal, and you can drill the bone and remove the ligament on the other side to expose the dura and to expose the two nerve roots. Next slide. This is a clinical example. It's a patient who was suffering from lumbar stenosis at level L4, L5, and I performed at this time a skin incision 2 centimeters from the midline on the left side because the main symptoms were on the left. And after that, you use that kind of a tubular system. You put the first one, second, etc. And you put finally the speculum here that is fixed on the mobile arm here. And you can change the orientation to expose the anatomical elements. Next slide. For that kind of surgery, I use magnificent loops, but you can use a microscope if you want. And it's useful to have a drill like this to achieve a decompression of the neural elements inside the canal. So you can drill the bone and expose very well the dura and the roots on the both sides. Next slide. This is a case report, an example, stenosis at the level L4, L5, and the approach was on the right side. So you can do on the other side, but the main symptom was on this side. And you can see, so you can see the stenosis here, the real stenosis. And this is on the right side, the postoperative CT scan. And you can appreciate that the decompression is good. Next slide. This is an example of a skin incision 6 weeks after the surgery. Next slide. This is an example of a two levels approach. Now, this is the case of L3, L4, L4, L5 stenosis. You can see on the myelo-RMI a huge stenosis at the level L4, L5, and a little bit at the level L3, L5, L3, L4. Sorry. This is the preoperative CT scan. You can see the stenosis here, and this is the postoperative CT scan, and you can see a very nice decompression, I think, at the level L4, L5. Next slide. This is a skin incision after 6 weeks, 6 weeks after the surgery. Sorry. Next slide. Now, this is a retrospective single surgeon case series conducted over a period of 2.5 years. It this 67 patients were included, with the majority of women and the majority of a single level. For 2 patients, it was in day hospitalization. And in the 40% of the case, it was 2 levels, and the rest of the case, 4 case. And the mean age of the patient was around 62 years old. Next slide. Thank you. Operative times range from 30 to 80 minutes. It depends on the number of levels to treat, with blood loss constantly below 50 milliliters, sorry. And the mean the mean hospital stay was 2 days, with reduced postoperative analgesic requirements, particularly with morphine. Next slide. I had 4 complications, 2 dural injuries, but no postoperative collection after. 1 symptomatic compressive epidural hematoma, which requiring a new surgery, and 1 superficial wound infection that had been treated by local treatment with success. Next slide. The clinical outcomes. We observe significant improvement in acute pain comparable to open surgery. As expected, improvement in low back pain was limited due to the degenerative nature of the disease. That's why I informed the patient that the primary goal of the treatment is not to improve low back pain, but to improve radicular pain and quality of work. That's why 6 to 12 months after the procedure, 65% of the patients are suffering again of low back pain. But you can see an overall patient satisfaction very high, 85%. The most part of the patient will recommend this technique to their family or their friends. And I didn't see any, at this time, any postoperative instability. Next slide. So the comparison with the recent literature showed that the most part of the articles shows that reduces perioperative complications, less blood loss, and low hospital stay. There is an exception, according to Chu and al. You have shown that showed that open decompression achieved greater pain improvement and lower reoperation rates. Sorry, but the majority of the medical articles shows that a good improvement in terms of pain, in terms of complication, reintervention, and it shows that it can reduce mobility and outcome comparable to microscopy techniques, for example. So it's comparable to my theory. Next slide. In conclusion, we can say that missed decompression is a safe and effective option for the treatment of lumbar spinal stenosis. It's very important to notice that it can be performed with or without advanced technology, making it accessible to most centers with classical surgical instruments. The postoperative outcomes depends on the patient selection, of course, the quality of decompression, and the quality of decompression depends on the surgeon's level of experience, of course. Next slide. So thank you for your attention. If you have a few questions. Now, it's a turn of Professor Benson. Okay. Our next speaker is Professor Behedin Musen, consultant neurosurgeon. His keynote speech title is Advanced in Brain Tumor Surgery in the Era and Evolving Radiosurgical Techniques Toward Precision and Preservation. Please welcome Professor Behedin Musen. Are you ready?
Thank you, Professor, for your introduction, and I would like to thank the organizing committee for this invitation. It was a nice lecture about MIS decompression. We do it as well over here in our practices, and I think it's very useful. Thank you for your lecture. Let me share my slides. Share. Yes.
It's sometimes difficult to share the screen. Okay.
Do you see my slides now?
Yes, there is a message from Zoom. Yes.
I
Hello. Oh, yes. Yes, we can
see.
see the slide now. But it's not
Listen.
in full screen. Huh? Yes, now it's good. Thank you.
All right. So thank you. I would like to thank the organizing committee again for this invitation. And I wish I could in Dubai, but my practice is very busy nowadays. I have so many patients waiting and surgeries to be done. So my presentation, I will take the audience to different topic. It's about brain tumors. It's a very common disease, and it has a huge burden in our healthcare system. I am a consultant neurosurgeon, and I have done a good number of cases of complex brain surgeries. Next. I have no disclosures. This is a few of the my brain tumor cases. First, again, brain tumors has a major burden in the Middle East and around the world. The management depends and it's different between surgical intervention, chemotherapy, radiotherapy, stereotactic radiosurgery, including the gamma knife, which is a minimally invasive tool that has been improved over the last years, and it has been uh, broadly utilized in our practices. So again, we are speaking about multidisciplinary management for this disease. First, the gamma knife radiosurgery or the stereotactic radiosurgery. Basically, it's a focused radiation that hit inside the brain without the need for incision. So it's considered a minimally invasive approach. It's a same day procedure and it treats small deep lesions and multiple lesions at the same time. We cannot use the stereotactic radiosurgery in all brain tumor. Common indications include brain metastasis, meningioma, schwannomas, and either as an upfront treatment or as an adjuvant treatment. What we mean by adjuvant, it's like you do surgery first, then you utilize the stereotactic radiosurgery. This is one of the important paper that we published by our group during my training time. It's speaking about the effect of the stereotactic radiosurgery in a brain metastasis. This is for the posterior fossa. So posterior fossa, basically, it was thought to be forbidden to utilize the gamma knife radiosurgery because of the risk of the perilegional edema and the risk of herniation. But in this paper, when you select the proper patient, this technology can be utilized safely. This is the perilegional edema during and the impact on the fourth ventricle during and after the treatment with the gamma knife for the posterior fossa tumor. Can we apply all the patient with this technology? Certainly no. When we speak about a single symptomatic lesion in the posterior fossa with a mass effect, surgery still has some role. And the new trend right now is to do stereotactic radiosurgery before the surgical intervention. So you do the stereotactic radiosurgery, in 2 or 3 days after that, you resect the tumor. And why we do all this? To minimize one thing, the risk of leptomeningeal spread that happens in the brain metastasis patient. When we speak about LMD, it's around 10 to 15% in patient in the best hands, and the patient with posterior fossa brain metastasis. Again, the dilemma between surgery and radiosurgery, there is a lot of gray zone in this area. When we utilize surgery versus radiosurgery or the gamma knife, it depends on the number of lesion, how badly symptomatic the lesion is, and the presence of acute neurological symptoms. As for in this case, it was very close to the premotor strip, and was a diffuse edema. So I took the patient for surgery. But in this patient, if he has a multiple other small lesion, I probably, and the patient on chemotherapy, and the patient overall survival is weeks, I will go to the gamma knife side instead of doing a surgery and interrupt the treatment, the systematic treatment of the patient. So the Gray's wide multidisciplinary team to be considered in these patients. This is one of the huge brain metastases with brain herniation. I took the patient to the OR directly. You can't utilize the stereotactic radiosurgery or the gamma knife in this case, so you have to operate on these patients. So we have once you know the proper indication and the proper utilization of technology, you can safely apply it in your practice. This is the patient that I speak about, huge brain metastasis. I took the patient. I think he has survived for almost close to 3 years despite this huge brain metastasis. And the primary was a metastatic liposarcoma from the thigh, which is a rare tumor for sure. And this is one of the application of one of the technique that we apply in gamma knife radiosurgery in skull-based meningioma. This is the fractionation, where we fractionate or treat the patient over days instead of single fraction to minimize the risk of neurotoxicity to the adjacent cranial nerve. This is an elderly patient. This is the patient that has a meningioma that has been grown slowly over years. So it's a growing, asymptomatic a meningioma in an elderly patient. So the fractionated gamma knife radiosurgery is an unsafe option for this meningioma. This paper came to the Neurosurgical Focus journal about the technique of fractionation and its safety in treatment of skull-based meningioma. This is our paper. Eh,
এখন আর দুটো পরীক্ষা নিয়েছি একটা ভালো বলেছে রিভার্স প্রেজার দিকে অলরেডি নেওয়ার চেষ্টা করতেছে বলতে করতে
What's
Mr.
happening?
Can you mute your
Not here.
mic? All right. So again, we cannot apply the fractionation in all skull-based meningioma patients. This patient has a symptomatic visual field deficit with big planum sphenoidale meningioma. So I took this patient to the OR directly. It's not wise to apply a gamma knife radiosurgery on this patient. This is the video of my patient. So I apply what we call a retractor-less surgery. Oops. We apply what we call a retractor-less surgery, in which I use a dynamic retraction instead of putting a fixed retractor in my patients. I think I just
We've lost your presentation.
exactly. This is what I'm trying to figure out. So when I put me to the video that speaks about the retractor-less surgery, see how I can stop share and let's share again. All right. You see my screen, correct?
Yes.
All right. Do you see my screen, right? Okay. So again, when we speak about the technique for the skull-based meningioma, I don't apply a retractorless. I apply a retractorless surgery in which I put a neuropathy or cottonoid, and I put my suction. I do a dynamic retraction and the tumor resection. This is a planum sphenoid. This is a sphenoorbital meningioma with orbital invasion. Here you cannot apply radiation. You cannot utilize the gamma knife radiosurgery. So I took my patient to the OR and I resect this tumor. This is this case example about how you can apply both technique. This is a massive middle skull base meningioma. It's a medial sphenoid wing meningioma, compressing the optic nerve, invading the cavernous sinus, and has some suprasellar extension. I resect the tumor and I have applied the stereotactic radiosurgery for this patient, and he has excellent quality of life after that. And I'm following this patient for more than 3 years. So either we use it as an upfront, or either we use it as an adjuvant after you do the resection for the tumors. This is another redo case that I did. The patient has 2 previous surgery radiation, and he's coming with a compromised vision. He lost a vision in one eye and compromised vision in the other eye. So I took this patient to the OR and I resect the tumor. This is the operative field. And then I follow this patient up for, I think, 1 year. Then I lost follow-up on him since I have changed my practice to a different region, but he was doing very good until I lost the follow-up. This is a primary intraosseous meningioma. This is a pure surgical case example. You cannot apply or utilize the gamma knife or the stereotactic radiosurgery. Can we argue with the technology? No, we cannot argue. The level of evidence of applying the gamma knife is increasing year after year. And this is one of the papers that speaks about the gamma knife in one of the other brain skull base tumor, the trigeminal schwannoma. Again, you cannot apply it for all the trigeminal schwannoma, but in properly selected patient, you can safely apply this technology, and it has shown a good tumor control rate and 10-year follow-up. So we have to improve our technique, moving from you applying our finger in tumor resection to applying more advanced technology and technique to minimize the nearby tumor, brain, or even spine soft tissue injury. This is an example of navigation guided resection, achieving Simpson grade 0 with removing the involved bone, and putting an artificial bone. As you mentioned, Professor Vinkov, you used the traditional open laminectomy and foraminotomy, and now you are applying more minimally invasive directed approach, achieving the same amount of decompression for the neuro and for the neural element and for the roots. This is one of the gigantic brain tumor that I used. The patient he was octogenarian. I think he was 85 with significant 5 comorbidities, including 4 stents in his heart. So I took this patient to the OR and I resect the tumor. And this is one of the paper that speaks about the safety of doing brain surgeries in patient over 80 years. So the age is not the limit, the comorbidity is not the limit, but the proper selection of the patient to which treatment is the major goal. Regarding the pituitary tumor, a common thing that we deal in our practice, this is a pituitary apoplexy that I have applied the forehand technique to resect the pituitary tumor. So I do these cases with my ENT colleague. At the end of the day, we are a neurosurgeon, so you deal or treat what comes up in your practice. This is one of the cases that I did recently. This is a clavicle chordoma that I would like to share about applying resection and a proton beam therapy or a conventional radiotherapy. So Isaac Newton say if I have seen further than others, it is by standing on the shoulder of giants. Thank you for this chance, and I would like to thank the organizing committee about this chance, and I'm happy to take any question.
So thank you, Professor Mussen, for this amazing presentation. So I was so impressed, because in my life before, at the beginning, I performed a lot of surgery for brain tumor, and I have appreciated the combination between surgery and gamma knife, for example, and I appreciate your vision of many invasive surgery. So I like it, and it was very interesting. So thank you so much for this very nice presentation.
Thank you
Thank
so
you.
much. Nice to see you.
We have a break of 10 minutes, and we will see further. Have a nice break.
बारह पाँच बारह
Hmm. Oh no. Theoretical block. Oh. Written. Has changed. Sorry. Not risky. Okay. So we can start the session after the break.
Good morning, everyone. Can you hear me?
Yes, yes, I can hear you. How are you?
I'm fine, thank you. Sorry, the timing I got was, UK time. It was 2:15. So sorry for this.
Don't worry. So I introduce you. Your next speaker
So,
is yes.
yeah. So good morning, everyone. My name is Mohammed Al Hindawi, and I am a senior clinical fellow working in UHW, United Kingdom. Today, I'm gonna present an interesting case regarding stellate ganglion block for management of refractory cerebral vasospasm following aneurysmal subarachnoid.
Okay, you have 20 minutes. You can go.
To start with, most of you know that cerebral vasospasm is a major cause of morbidity or even mortality after aneurysmal subarachnoid. Standard therapies like oral nimodipine, intra-arterial nimodipine, triple H therapy, including vasopressor inotropes and angioplasty and CSF diversion, sometimes fail in refractory cases. Today, we are going to present a case of stellate ganglion block for management of refractory cerebral vasospasm following aneurysmal subarachnoid. Regarding evidence, I went through the literature and I found 7 studies talking about the topic. 2 of them are randomized controlled trial. The first randomized controlled trial is a Chinese study, which is Zhang et al., and the other randomized controlled trial is a pilot study, which is Wu et al. The remaining studies are 2 prospective, 2 retrospective cohorts, and 1 case series. Most of the studies showed both not only radiological improvement of cerebral vasospasm after stellate ganglion block, but also showed clinical improvement. So the next slide, why stellate ganglion block? This schematic diagram shows the anatomical location of stellate ganglion, which is the fusion of lower cervical sympathetic ganglion with the upper thoracic ganglion. And it is located superficial to longus colli muscle and deep to prevertebral fascia. In vasospasm associated with aneurysmal subarachnoid hemorrhage, there is sympathetic overactivity. And when we perform stellate ganglion block, this leads to interruption of cervical sympathetic flow, which in turn enhance cerebral vasodilation and improve the cerebral perfusion. Our case today, he was a 53-year-old gentleman who presented with WFNS grade 5, modified fissure 4 subarach due to ruptured 6 millimeter ACOM aneurysm. On day 2, post-bleed, the patient underwent endovascular coiling of the ruptured aneurysm, and during the procedure itself, there was a severe vasospasm at A1, A2 junction, so intra-arterial nimodipine was administered. After the operation or after the procedure, the patient underwent right frontal EVD insertion for CSF diversion and was kept intubated, sedated in ITU for vasospasm management. While being admitted in ITU, the patient had a serial transcranial Doppler and CT angiogram. Despite maximal medical treatment, including oral and intra-arterial nimodipine, inotrope vasopressor and CSF diversion in the term of EVD, the patient developed the bilateral MCA vasospasm, which was more severe and profound on the left side. And this vasospasm has not improved with traditional treatment. The next slide, these are the axial and the coronal CT angio, which was done day 1 after endovascular coiling and before stellate ganglion block, which shows bilateral MCA vasospasm, and you can appreciate here it is more severe on the left hand side. Decision for stellate ganglion block after MDT discussion with our neurosurgery team, IR team, and ITU teams. The consensus was performing stellate ganglion block as a rescue therapy. Technique of stellate ganglion block. So it is a bedside procedure, ultrasound guided procedure. So we obtain the transverse plane with the needle visualized at the level of C6 anterior tubercle, which is Chazagnac tubercle, named after a French surgeon. The needle is advanced from laterally to medially towards the prevertebral fascia, superficial to longus colli muscle. Once the fascia was punctured, 8 mils of levobubovicaine 0.5% with clonidine 75 mic was administered. So the maximum dose of levobubovicaine is 2 milligram per kg, but in our case, usually it is 40 milligram instead of 140 milligram, which is has a large safety margin. There were no any complications occurred after this procedure. On the next slide, you can see on the left, this is a schematic diagram of left stellate ganglion block under ultrasound guidance. And on the right is the ultrasound guided stellate ganglion block, which shows the anatomical landmark and the ultrasound window. Here you can see the white arrows represent prevertebral fascia, and the yellow star represent the target zone for the injectate. Also, you can see here the anatomical landmark, sternomastoid muscle, internal jugular vein, common carotid artery, longus colli muscle, and vertebral artery and vertebral vein. So basically, the needle will approach from here, from lateral to medial, targeting the prevertebral fascia. And as we mentioned in the previous slide, once the fascia is punctured, we inject here superficial to longus colli muscle, and the injectate and our block will spread into surrounding the stellate ganglion and spread caudally and cranially. So why stellate ganglion block is preferred rather than superior or middle cervical ganglion? It is basically due to the safety of stellate ganglion block, because in cervical ganglia, superior cervical ganglia, it is quite high and deep. It is also near carotid bifurcation and the cranial nerve. It has a poor ultrasound window, so it is associated with more complication. And in middle cervical ganglion, it's quite absent in 50%, close to other structure like thyroid, recurrent laryngeal nerve, and it has unreliable block. But in stellate ganglion block, as we mentioned before, it has a clear ultrasound window, and it associated with lower complication rate. Also, the injectate will spread up and down. Physiological response, in our case, the next table will summarize the transcranial Doppler velocities in left MCA after stellate ganglion block. You can see here the BSV, which stands for peak systolic velocity, EDV stands for end diastolic velocity, and the mean cerebral blood flow velocity, and the Lindgard ratio, which is the flow or velocity in MCA over the velocity in internal carotid artery. As you can see here, all transcranial Doppler readings have significantly improved after stellate ganglion block. The next slide shows the actual reading from the Doppler ultrasound machine, which was summarized in the previous table. The top image was before stellate ganglion block, and the bottom one after stellate ganglion block. You can see here the peak systolic velocity in the top image was higher than 350, and after the block, the peak systolic velocity became under 200. And also, all the readings have significantly improved. Regarding imaging outcome, here is the CT angiogram, axial and coronal. The top image was day 3 after bilateral stellate ganglion block, which shows early improvement of MCA vasospasm bilaterally. And the bottom image, you can see here, it was day 7 after the block, and you can see here near normal calibers of MCA bilaterally. Regarding clinical outcome, so vasopressors weaned off, and our patient was extubated and transferred from ITU to neurosurgery HDU with a GCS 14 out of 15, and the right-sided weakness has improved with physiotherapy. The next 2 slides, we are going to talk about pros and cons of this procedure. Starting with the pros, it's a reliable and effective technique, feasible bedside procedure, and also it is quite safe procedure. Why it is safe? Because it gives us a real-time visualization of vascular structures, and we can see the needle tip, and also we can see our injectate, which in turn reduce the associated complications like intravascular injection, pneumothorax, and the neural injury. Regarding cons, it needs, of course, a learning curve in everything, in ultrasound anatomy knowledge, also the coordination between the needle and the probe. You might find difficulty in the beginning to identify prevertebral fascia and the longus colli muscle, and also to be more confident and comfortable doing this procedure, you need at least 10 to 20 cases done under supervision. And because we are doing sympathetic block, so Horner's syndrome is expected. Sometimes repeated injections required. Conclusion, the case we presented today showed the physiological and the clinical benefits of stellate ganglion block in management of refractory vasospasm following aneurysmal subarach, which was initially non-responsive to traditional treatment. These are our references, and thank you.
Well, thank you for your very nice presentation. I have two questions for you.
Yeah.
The first one is what is the ideal timing for performing the injection? I think as soon as possible after the vasospasm.
Yeah, so basically, what we do here in the UK is this stellate ganglion block is not a common practice in the UK between neurosurgeon, but because in our unit there is like a doctor which is very efficient doing this, so we started to do this procedure recently, and basically this patient, because he had a poor WFNS grading, and on serial TCDs we found this vasospasm velocities. So we started immediately to do stellate ganglion block after MDD discussion with other teams, the ITU team and our IR team.
Okay, so this is a multidisciplinary discussion.
Yeah,
It's good.
exactly. Exactly.
And the second question is what is the duration of the therapeutic effect of the block?
So this TCD readings immediately after 1 hour from the block, we noticed significant improvement of the velocities as we mentioned in the summarized table. So this table was like 1 hour after the block. The table I just presented, which is this one, it was 1 hour after the block.
Okay, and what is the frequency of the Claude-Horner syndrome?
So basically, Horner syndrome, it is a physiological response. So you should see it to know that you did a perfect or effective block. So it is like indicator that you did a nice block.
Okay, so thank you for your response and congratulations for your presentation. Thank you so much and have a
Thank
nice
you.
day.
Thank you. Cheers.
So the next speaker will be Dr. Prishil Kumar Gupta, and he will present a poster. And I'm looking for the title of the poster. Ah, yes. This doctor is from India, and his poster presentation title is Study of Computed Tomography Evaluation of Craniovertebral Junction in Asymptomatic Central Rural Indian Population. So please welcome Dr. Gupta. Are you here? Please? Are you present? So we're waiting Dr. Gupta. Sorry for waiting. Huh? He's not available. Okay. So there is a problem with Dr. Gupta. He's not available. So the next presentation, please. Okay. So we're waiting the Dr. Gupta's slides. It's on the way. So be patient. Take notes that certificates would be provided to speakers, poster presenters via email after the conclusion of the day 2 session. Thank you. Oh, just 15 minutes. Session. Okay, in 5 minutes, I think it would be okay to see the next presentation. Okay. So the next speaker is Dr. Prashel Kumar Gupta from Bhopal, India, and he will present a poster. And title's poster is Study of Computed Tomography Evaluation of Craniovertebral Junction in Asymptomatic Central Rural Indian Population. So, where are you, Dr. Gupta?
Hello.
Oui?
Yes,
Yes?
can I start my presentation?
Yes, but I don't see your slide.
Uh,
I can see your slide.
Screens.
So you have to
Can I
share your
see?
screen.
Can you see?
No, nothing.
Nothing.
No, sorry.
Okay, wait.
I have sent a message to the technical team. Alors, yes, it's on the. Yes, it's okay now.
It's okay?
Yes, I need a full screen if you can.
Yes?
Yes, it's okay. Thank you. Sorry.
Yes.
So welcome, doctor.
I
And
am
you
from
have
Bhopal, in Madhya Pradesh state in India.
okay. So you have 15 minutes for this presentation.
Yes, please. So I am. Thank you for letting me speak in this conference. Hello. I am presenting the study of computed tomography evaluation of craniovertebral junction in asymptomatic central rural Indian population. So the background is like that. It is why we have conducted this study. So because the craniovertebral junction is a very complex and highly mobile region, and any minor anatomical variation here can cause the significant neurological compromise. The region there is every major structure is there in that region, means there is artery, there is vertebral artery, there is a venous plexus, there is a spinal cord, and the and including it has the most mobile region of the spine is also there. So the study which we have done is the normative data, means we have conducted what should be the average average parameters, average significant parameters in that region, so that we can have accurate diagnosis, we can have accurate surgical planning, and sometimes we can avoid over diagnosis of instability since we know the normative data. This study is limited to the Indian and rural population, means the study is mainly focused on central Indian rural population. So the whole of this study is based on that only. The objective, what are the objectives? So it is to establish normative morphometric parameters of craniovertebral junction. We have in this study we have studied what are the age related variations, means according to the age do they parameters change, or they are same, or there is any decrease or increase. Also in this study we have find out the gender related differences, means between males and females. So in this study our objective is to generate a population specific cutoff values, means the cutoff values after which beyond which we can say that it is abnormal, or it comes into the diagnosis of some pathology, some kind of pathology. So, study design. It is the study was of 1 year. It was retrospective observational study. It was conducted in neurosurgery and radiology department together. and it was conducted in our tertiary care rural referral center. In a 1 year period, we have collected total 255 cases. So in those 255 cases, 175 was male and approximate means 80 were female, and the age range in our study varies from 2 to 95 years, and mean age in that study came out to be 42.9 years. So how we have included these 255 patients? So we have conducted this study on a normal patient, but we haven't assigned with ourselves. Uh, the inclusion criteria came like that: though head injury patient which came to our department in an emergency with normal CT brain and spine, means there is no fracture, no instability, no loss of consciousness, no neurological deficit, but they have undergone CT spine and brain as a routine procedure for selected cases. Those patients we have selected in our study. So the parameters which we have measured were anterior atlantodental interval, the posterior atlantodental interval, clivus length, foramen magnum diameter, Bougard's angle, and basal angle. The figure A here, it demonstrates anterior atlantodental interval, the red line, which is a small line in A figure. There we can find out what is the anterior atlantodental interval. The figure B, it shows how we have measured posterior atlantodental interval. Figure C, it shows how we have measured the clivus length. Figure D, it shows how we have measured the foramen magnum diameter, and figure E and F, it is for the Bougard's angle and basal angle. These angles are important for diagnosis of platybasia or basilar invagination or some craniovertebral junction anomaly. So we need to find out what should be the exact or what is the cutoff for the average population in central India by using that data of 255 patients. So the overall results which we get where the mean values were found to be like the anterior atlantodental interval, it was 1.3 millimeter. The posterior in those 255 patients, the posterior atlantodental interval was 16.7 millimeter. Clivus length was found out to be 44.91 millimeter. Foramen magnum diameter was found out to be 34.03 mm, and Bougard angle was 129.14 degree, and basal angle was found out to be 130.24 degree. Our data shows wide range in age related variations. So how it was like, I will just summarize later. Now for gender based comparison, in the anterior atlantodental interval, I did not find any significant gender based comparison. But in the posterior atlantodental interval, clivus length, foramen magnum diameter, Bougard angle, and basal angle, I found that male and female, the means the mean value was statistically significant. Means there should be a different cutoff for both. Means this implies male values were generally higher than female. Here I have put the table where the average.
هو اليوم الثاني اونلاين للكل بس اليوم الاول حضور.
Pardon?
Sorry. Can you check your microphone, please? Not you, not a speaker, but the person that was speaking now. Okay, you can continue. Sorry.
So the data which earlier I told was the average data for male and female, but for individual male and female, this study is here we found that p value is 0.22. It means it is not significant, but 0.16 means for all other it was significant difference in the posterior atlantodental clivus length, foramen magnum, Bougard angle, and basal angle. It is different for female and male, but for anterior atlantodental interval there was no significant difference. Now for age based comparison, I have compared for less than 22 years and for more than 22 years. So I found that according to age, there is statistically difference in the diameter of anterior atlantodental interval, clivus length, and foramen magnum diameter. Um, so this is the figure where I have means compared, and these are the p values which where I found out after applying the t-test. So in this from this data, what I have derived is the cutoff value for anterior atlantodental interval for less than 20 years should be 2 mm, and means it is more than 20 is 2 mm, and less than 20 it is 2.6 mm. Cutoff value for posterior atlantodental interval, it comes out to be 13.5 mm. For Bugard angles, it was 141.84 mm. These are the cutoff value after means applying the standard deviation, means above 95 to standard deviation confidence limit. I have placed the cutoff values. So means anterior atlantodental intervalues were comparable with the previous international studies. Other parameters which showed population specific variations, maybe it is due to racial and anthropometric differences, or it may be rural population characteristics, maybe due to some nutritional deficit or some other thing. So our study, what it highlights is it highlights the what is the region specific values. So next slide. Conclusion: what is the normal CVJ parameters for Central India? We have established that it is means in our study we have normative CVG parameters for normal center rural India population. In our study, it is concluded that a anterior atlanto or dental interval cutoff differs by age group. Other CVJ show distinct cutoff values which we have mentioned. So this study can be extrapolated to similar rural population, and it helps for better interpretation of CVJ imaging. These were the references which I have used in my study, and so thank you for
So,
letting me presentation.
so thank you, Dr. Gupta, for your presentation. So it was so interesting. But I have a question. What is the incidence of this pathology in its symptomatic form?
In India, it may be around means for cervical spine 3 to 4%.
Okay. So thank you. It's yeah, so that's a low. Okay. So thank you and for your presentation, and have a nice day. Thank
Thank
you.
you. Thank you.
So now it's my honor to introduce our next speaker, Dr. Antonio Francisco. And he will be delivering a speech on artificial intelligence in neurosurgery. So please welcome Dr. Antonio Francisco, and you have 20 minutes for your presentation.
Okay, thank you very much. I'm trying to upload. Can you see it?
No, I see I cannot see your slides.
So just hang on a second.
Mhm.
And now,
Yes,
can it be seen?
now it's okay. It's
Okay,
okay.
so
You can
thank you
begin.
very much. It's an honor to present my paper, me and Dr. Sergio Livraghi, both from Lisbon, on artificial intelligence in neurosurgery. So our work had to do with bibliometric review and analysis across PubMed, Scopus, and Web of Science for papers that were related to artificial intelligence, and neurosurgery. Around 200 core articles were included, and on 183 articles, a final analysis could be done. The inclusion criteria were peer-reviewed original research or reviews that had been published since January 2017. We also analyzed the direct relevance to neurosurgical practice and outcomes. In terms of the analysis framework, we tried and categorized by input from different countries, input for different areas of neurosurgery, the AI techniques that were utilized, and in what type of the neurosurgical treatment pathway they were used, either preoperatively, intraoperatively, or postoperatively. So in terms of the number of papers, we can see that in the beginning 2017, less than 50 papers were published, and there was a steady increase in the flow of papers that have been published. Most of all in 2024, because we were not able to allow for the full year of 2025 when we made the presentation of the abstract. It also has to be said that some of the AI models that were used have been evolving through time. And the most important in this exponential surge that has happened seems to be the arisal of ChatGPT on 2023. There were a number of papers that were published until, I would say, the birth of ChatGPT, and after that, everything increased. And as we speak, probably another new papers are being presented according not only to ChatGPT technologies, but to other AI technologies. This gave rise to a specific spike in the release of papers. In terms of the main contributors, this is related to most areas of neurosurgery and nowadays presentations or articles that the most output came from the United States. There's not only a distinction between countries, but also the focus according to the country. Mostly the United States articles were related to clinical applications, spinal surgery, and large language models evaluation. We also had some China output relating to algorithms for deep learning and also tumor segmentation. From the United Kingdom, we had concerns related to ethics, systematic reviews, and training. And we also had from other European countries regarding board exam analysis and neurological surveys. In terms of type of article breakdown, most articles, as would be expected, were reviews. Original research was in 30% of the cases, most of them retrospective studies. Some of them relating to algorithm validation, but mostly retrospective studies. Some 20% were related to editorials or similar like articles, and 5% had to do with case reports in particular cases. In terms of the clinical field distribution, most papers deal with education, such as is happening today, and general AI, related, for instance, with board exams, the possibility of making automated discharge summaries, others related to the ethics of AI writing, and also related to, for instance, brochures for patient education or the education itself being made by AI chatbots. In terms of neuro-oncology, the other main subject, mainly related to glioma segmentation, and here we have an example of the different areas of the brain tumor patient where AI can be important. It can be important to the neuro-oncologist. It can be important AI for the neuroradiologist in terms of tumor segmentation. It can be important in the neurosurgical, not only for surgical margin reassessment, but also for the programming of the resection itself. And for instance, in the future, it is envisaged that there might be a link between robotics and AI and the intraoperative flow. Also with the neuropathologist regarding tumor detection and tumor classification. And most importantly, on the molecular pathologist, because AI has been being used in this field in a way. So this is an example of use in neuro-oncology. Spine surgery has also been very active, almost the same as neuro-oncology, not only in predicting complications, but also analyzing images, either X-ray or lumbar fusion outcomes, for instance. Vascular and functional have not been excluded, and for instance, aneurysm detection, stroke prediction, and optimization of targets for deep brain stimulation have also been tried. Here is an example of the ChatGPT and the analysis of how well does ChatGPT do in a board exam. In the American exam, ChatGPT 4, we have to pay attention to what kind of model we're talking about. We have newer models that probably fare better than these models. We have an accuracy of around 75% in the American model, and for the European exam, around 80%. This is an example not of neurosurgery, but of the exams of USMLE type questions and how well does ChatGPT perform in terms of the difficulty of the questions. Very easy questions are very easy for ChatGPT. Very difficult questions are very difficult not only for real persons, but also for ChatGPT. But we are talking about older models of ChatGPT. There's one instance that might be already being addressed now, which is called the image gap. So when the questions that were raised for both the person or the ChatGPT in terms of exams, if we had text, then there would be a high accuracy rate above 75%. But when it comes to visual analysis, the ChatGPT 4 version had only above 50%, not above 75%. So this was considered low. And for Gemini, even lower. The truth of the matter is, as we speak, now we have models that are not only based on large language models, but also models that are based on imaging and video acquisition. So these models nowadays fare better than the ones that were studied before. Important ethical issues that we came across in our bibliometric analysis. The liability. Who is liable if we rely on artificial intelligence, and then who's going to be liable? Well, there is a consensus on this, that if there is a misstep regarding AI tools, then the liability will always be on the surgeon or the practitioner. Another problem that was commonly addressed was large language models and deep learning allow us to reach conclusions regarding the relationship between two variables, but they not always let us explain the relationships. So AI sometimes finds not necessarily causality, but relationship or association between variables, but it's not always transparent as what kind of relationship there is. Another important issue is on the intensity of the data needed. For instance, for surgical analysis, a high intensity of training is needed. So not always AI allows to forego the human factor. In the first steps, the human factor and high training intensity is needed to achieve better outcomes in the future. Another also very important issue is related to the academic integrity and the risk of what is called hallucination in AI models. Whenever AI models hallucinate, this can lead to data that might not be reliable, and that data that quotes itself on and on and on, called automated plagiarism. This data fabrication is related to what is called outside the medical field as hallucinations. That means that artificial intelligence might tend to introduce data where there is no data. So there are different approaches. This is not a consensus, but the different approaches to this problem. One is the zero trust approach, which means that peer reviews should assume that AI has always been used. Another issue is the use of AI detectors to try and understand using AI against AI, so that AI notices when AI has been overused. And this might lead to a retraction spike of articles and papers. This has led to some propositions for the future. A strategy evolving from not using AI to a mandatory disclosure of AI, such as disclosures are usually already mandatory for all other aspects of what is used in building a paper, namely financial disclosures. Not in methods transparency, then the use of AI, and in that case, this both our presentation and both our paper and abstract were used using AI tools, then reviewed by humans, of course. In terms of clinical success stories, well, this is an example of tumor segmentation and how AI can help and decide what is tumor and what is not, what is radionecrosis and what is not. But for instance, in the vascular field, subarachnoid hemorrhage detection has been able on non-contrast CT scans, and it has led to the belief that it might be as useful as specialist analysis. Also, this not foregoes the need for a specialist, it just can be the same. In terms of automated tumor volumetry, such as illustrated here, it is totally comparable to what radiologists can do. Other practical utilities and specific cases in spine surgery. Deep learning models can be used with 90% accuracy for X-ray interpretation, but we mean X-ray interpretation. This is different from CT interpretation or MRI interpretation. This is not the same level. In terms of surgical planning, such as it can help with planning in deep brain simulation, it can also help when we relate to the trajectory of screws or the planning of a spine surgery. There's also one case in particular regarding CSF shunt valves on X-ray. 99% of cases were identified the implanted CSF shunt valves on X-rays. Another important issue is related to cranial prosthetics and the use of AI-driven tools to create better prosthetics and how this might drive the field. These are all examples of success stories on all the spectrum of neurosurgery. What can we envision for the future? We can envision transitioning from the artificial intelligence alone model to an augmented intelligence, or the interface between patients and machines, surgeon and machines, and hospital and machines, because many aspects will be impacted. The data from the patient, the communication with the patient, also in terms of hospital and healthcare management, other specialties that deal with the patient, not only doctors, but also nurses might be using this in the future. So nowadays, artificial intelligence is being considered more as a co-pilot model, not as a pilot, but as a co-pilot model that supports and enhances human decision. It has to be taken into account that as of now, artificial intelligence is not a substitute for human reasoning. So there should be some humility in the use of artificial intelligence. We consider this the consolidation phase, but I think we are more in an explosion phase. The last news that we have from the AI big players are going to the point of saying no need of taking a medical course anymore, because AI will take over doctors, not only non-surgeons, but also surgeons with robotic surgery. Of course, this is hype. There are no articles right now that allow us to say this, but this is what the big players of AI are saying right now. This is not where we see when we look at the articles. Right now, what we see is consolidation phase. There has been a spike, and now many articles are coming out on different aspects of AI. the performance gap, well, mostly related to what are written exams and visual exams. But as I said, new foundational models have been developed to address specifically imaging. So we think that this gap is probably vanishing right now as we speak. Regarding ethics, the need probably to disclose the use of AI and of use AI to chase AI and realize where AI has been used and not being disclosed. As a final thought, and as a big question that lingers for us when we did this work, um, artificial intelligence, as it allows to be used as a co-pilot for doctors. And for instance, in imaging, it can sometimes detect tumors at the same level as a specialist. This would allow, maybe in less favored areas, for us to have better care. But we have not seen articles addressing where are areas of the world where the access to quality of care is difficult and how AI might mitigate that. So this was the final thought that we like to leave. If AI keeps the promise to be a game changer for medicine and neurosurgery, in what way would this allow us to have the best of care in places that nowadays don't have access to the best doctors in person, but that might have access to artificial intelligence tools? And I leave you with that. Many thanks for your attention.
So thank you, Dr. Francisco, for delivering an insightful speech on artificial intelligence in neurosurgery. So I had a question. This raises the issue of the criminal liability, OBA, of the surgeon. So we will see, I think, in the future, the problem of penal responsibility or civil responsibility. What is your feeling about that?
I thought you were talking about legal issues, right?
Yes, yes.
Okay, so my personal belief, and we saw that in most articles that address the ethical question, is the responsibility will always lie with the surgeon, with the doctor. We use AI as a tool. We should address and say we did use AI. But if something goes amiss because we were over reliant on AI, then the responsibility will always be, at least as the time being, will always be not of the producer of the AI, but of the user of AI, which means the surgeon.
Okay, and if you would have a crystal ball, would it be the end of the handmade surgery or not?
Well, as for now, I don't think it will replace our generation of neurosurgeons or the ones who are watching. But I think the next generation will have a very different paradigm because not in neurosurgery, but in other areas, like for instance, for cholecystectomy, we already have the announcement of simulator sham surgeries being done by robots, not in patients, of course, sham surgeries. But we already have the segmentation, not of the tumor, but the segmentation of the surgical process. And then we can have the robot and AI being able to identify the different phases of the surgery, dealing with it and dealing with potential complications. So I don't think the current generation is going to be deeply affected or out of business. But the next generation, the motto is maybe AI won't replace doctors or neurosurgeons, but the ones who use AI will replace the ones who don't use AI. That's the main.
Okay. So thank you for your
Thank you very
fascinating
much.
presentation. So thank you. This session marks the end of the session. So thank you for all our speakers, exhibitors, poster presenters, and participants for your valuable contributions today. So this is the end of the day 2, and you will receive by email the certificate. And so thank you for all, and have a nice day. Thank you. And invite you to join us to our future conference, which will be going on in the October 2026. So see you later, and thank you for all.